Over the next 30 minutes, I intend to give you an overview of my role as the Emergency Value Stream Manager at Portsmouth Hospitals, a post I have held since January 2008. I've worked in the NHS for 20 years. I'm a nurse by profession and have held a variety of senior nurse, managerial and operational roles during this time. When considering whether to apply for the post, and Dan, I was appointed, I actually wouldn't have volunteered if I know what I know now, but I did apply. I asked what a value stream manager was. Mark replied, "You will be the champion of the patient's perspective. You will oversee the horizontal journey of the patient throughout their stay in hospital. You will bring together the silos of work that currently are divided because of the organisational structure that most hospitals have. Ours are called divisions." It sounded an interesting job, a bit of a challenge, and it fitted the philosophy that I was currently following in my role as the Access and Capacity Manager. So I applied. Little did I know what came next. And it wasn't fighting with a rhino. As Dan has stated, this is a new role, an experiment, or in the NHS we tend to have trials. But over the past year, we have reflected on the characteristics that you need to be successful as a value stream manager. I feel that you have to act as a role model. You have to give sound information and advice. I had the clinical and the operational credibility. What I didn't have is the lean methodology, the knowledge of those new skills that I needed to quickly adapt and quickly learn. I'd worked in the NHS for 20 years. I'd been brought up in the NHS way of leadership and management, and it was incredibly difficult, and still is every day, to put those aside and to take these new ways of working. And personally, for me, I have found that the biggest challenge. I had to manage expectations and continue to do that. These can be from the board, that lean is going to save thousands of pounds, reduce our length of stay, and we're going to do it all by the end of month 2. Manage the expectations of the frontline staff. And there, in a way, it's much simpler. They want you to work with them, improving the quality of care that they give their patients and the quality of experience for them each time they come to work. I've needed to have portrayed to me that there is committed and demonstrated support from those around me. And I've needed to display that when everything is wobbling and no one's quite sure about lean anymore. I've needed to have a willingness to succeed against all odds. And at times over the past year, I've wondered if I'm actually turning into Margaret Thatcher. This lady is not for turning. I've said more than once inside my head when I've come up against many battles and many obstacles. And the skin of a rhino? Well, Helen from the Lean Enterprise Institute asked me last night if I donned my armour each day before I went to work. And sometimes it does feel like that, an uphill struggle, a battle. However, as I said to her, my armour is my desire to continue to improve the quality of the patient's journey. The rhino turning up and down reflects the large amount of gin and tonic that I've drunk over the past year, keeping me sane. And most of that's usually at the end of a hard day when Mark and Ian and I are reflecting on how it's gone and how we're going to do it next time. Mark suggested that the value stream manager role is about connecting the silos along the patient's journey. For most hospitals, the silos are made up of both internal and external groups of departments, all providing support along the patient's journey. My relationship with these departments, in my case divisions, had a very rocky start. Initial discussions around the creation of a value stream manager role were met with both scepticism and opposition. What impact would the role have on their divisions, how they ran their divisions? They had accountability and responsibility for everything that went through those divisions, for how their teams worked and for their budgets. What role would the value stream manager play in that? Would the value stream manager be spending money from their budgets they had no control over? Would the value stream manager be making changes that they didn't agree with? To name but a few. The answers to these questions became, not for me really, but became clear to them when they began to understand the current state of where their divisions were and the impact they were having on the patient's journey. And as we started to agree what the future state would be. There was quickly an initial acknowledgement that as divisions, they were not working together for the best interests of the patient and the journey. Neither were the specialities within their divisions either working with each other or across the divisions. Their silo working became more and more evident as we moved along our lean journey. The example I'll share with you links to the cardiology division within medicine, who actually started a lot of their lean work before LEA joined us. They worked exceptionally hard to reduce the length of time a patient waited to be transferred to our cardiac surgery centre, and yet they were still finding obstacles, wasting the patient's journey. This was coming from services outside their control, outside their division. The patients required a dental assessment from a service within the surgical division, yet not grasping the concept of lean, and they would continue to batch assessments. My role as the value stream manager was to hold a meeting with the key stakeholders, identify the problem, gain understanding of the planned future state, and each individual person's within both those specialities across their divisions role with solving the problem. Identifying the root cause, which was batching of the referrals for the assessments, and then implementing a new process that assured that batching was removed, waste was eliminated, and the patient's journey, which had fallen between those silos, was smooth and timely. I thought long and hard about this slide and the title of my presentation. Who does the value stream manager need agreement to act from? Actually, it's everybody throughout the whole of the organisation, from the top down to the bottom up, at different times, in different ways, and at different levels. But it's important that as the value stream manager, I take time so that everyone understands and acknowledges that the horizontal aspects of the patient's journey that currently fall between those divisions are where we need to gain that agreement to work together. The slide that I put up now shows the reporting structure, not the organisational structure that I work within, but the reporting structure for the work streams that we're currently working on the emergency pathway. So our agreement to act is led by our Chief Executive. She chairs our steering group. Important to us when we were creating this reporting structure was that we had the Chief Operating Officer and the Director of Nursing. So both the operational and the quality agendas were used to bridge the patient's journey. Really important from a safety point of view, but also from a target point of view. And that's balancing both the agendas and the political issues that both those people lead on. One of the wisest moves that we had was actually to invite a non-executive director to sit on our steering group. Hand-picked because of his experience and his knowledge of lean within industry. Probably our best move so far. What he's been able to do is be our champion at board level, which is essential. He's been able to dispel myths and manage their expectations. Prior to us bringing him into the fold, what we would hear after each board meeting is that someone, and a different person the next time, as soon as the problem had been identified, had said, well, what are Lean doing about it? Can't Lean help? Let's get Lean in there. Not really understanding Lean and the methodologies and the time that it took for them to identify the problem and to solve the problem. So once we had Mark on board, it certainly helped with their understanding and continues. Sitting under the steering group, we have a core team of senior managers. So that's the box on your top right, the yellow one. A core team of senior managers who agree and overview the work streams that are identified across the emergency surgery pathway. They have a pivotal operational but also a strategic role in supporting the Lean facilitators that we have employed. If you remember that Portsmouth Hospitals has over 1,000 beds, recently joined together on one site, and over 7,000 staff, 5 facilitators don't seem very much, unless, of course, you're sat on the board with a budget to meet and targets to meet, and then you think we were about to save the world by the end of the week. One other important decision that was made before I came into post was to ensure that we had a data analyst sat within that core team of facilitators, and she has been invaluable to us, and certainly that would be a piece of advice I'd give, to ensure you have a key person out of your business intelligence or your performance team that is dedicated to any work. On the left-hand side of that screen, it demonstrates that we meet both formally and informally with our LEA partners on a regular basis. To me, as a value stream manager, the most important aspect and line of the slide are the 4 mauve boxes. These are the divisions, so medicine for older people, surgery, medicine, and clinical support. And actually, when I was putting my talk together, it perfectly demonstrates how they work in silos. So those 4 divisions aren't actually adjoined at all in that slide, and sometimes during the day, and certainly for the patients on their journey, it feels like that. What I've implemented is to meet with those divisions on a monthly basis. Obviously, I see them more regularly than that, and sometimes our corridor conversations are the most useful. At those monthly meetings, the facilitators leading on the projects within their divisions, their clinical leads and managers within those areas, give us an overview and an update on how the work streams are progressing. We try to follow the Lean methodology of having an A3 to work to. That took some time. Have people at a meeting who don't actually understand the process or what you're talking about is actually quite interesting. It enables us to identify problems, escalate blockages, undertake root cause analysis, agree a way forward, and have an open and honest debate on issues raised. It also gives us the opportunity in a safe environment to transfer knowledge and skills. Lean is quite new still to the NHS and quite scary to some people who don't understand it, but as a divisional management team have responsibility for what's happening within their division. It's also the meeting where we discuss future projects and agree on timescales and on contracts. Dan said this morning, tackling the emergency value stream is a nightmare, and it would not be wise to go there. Oh, I wish he'd told that to us a few years ago. Obviously at Portsmouth we're not wise, and we have gone there, and we are tackling the emergency value stream. To us it was the most obvious one to tackle. It is our most broken. The slide here shows you our deployment matrix. It details the activities we have committed to undertake to improve aspects of the patient's horizontal journey as they move through that emergency pathway. To get to this point, we needed to take the Trust's objectives, which, if you can see them, are in the bottom left-hand corner. We had to turn those into the objectives that, as the Process Excellence team, and I sit within that team, so these were turned into our agreed objectives. We needed to work with the divisions about what their improvement targets were and make them our improvement targets. And then we needed to create A3 plans for all their activities that we were going to undertake to achieve the trust targets. So not much to do. All this whilst coping with the operational pressures of working within and helping to manage a busy district general hospital. When I first saw this, it sort of blew me away, really. Having worked in the NHS for 20 years, I could cope with a business plan that was a bit like a tomb that I took home at the weekend to read. That was easy. Could write them, could implement them. But this was slightly different. But what LAA have done, they have taken us through this step by step, broken it down so that we can understand it, and it's an incredibly simple way of monitoring month by month your achievements, both as individual work streams, individual facilitators working with clinical partners, and as a team. I have to report to the Hospital Management Committee once a month on the Process Excellence team and our achievements. I used to take a report, which was pages long. Nobody had read it. I had to read it back out to everyone, explain what it said, whilst everybody yawned. I've been very brave lately, and my tomb I take each month has got smaller and smaller. And now, in true lean principles, I take my updated matrix, and I take my dashboard of performance to show what we have. I take my performance dashboard. Two edges to that. One, it's educating people on lean and following lean principles. Second one is, I think nobody has absolutely any idea what we're achieving. So it doesn't matter whether we've had a good month or a bad month. They're not sure what's going on anyway. What challenges have there been along the way that has prevented us from acting? We have very limited ops management, I feel, in the NHS, although we seem to run about all day pretending we're ops managers and we're managing the process. I think most of the time it's managing us. What we implemented at Portsmouth was a team of duty hospital managers which would release on-call managers, operational managers to do their day job. And we have a dedicated senior manager on 24 hours to operationally manage the hospital. That has freed the clinical or the speciality managers up to concentrate more on their own areas rather than the overview of the hospital, to move away from that incessant bed management that eats into our time. I've talked about data. Essential to have someone within your team to gather that data for you. I would say her biggest challenge is the availability of timely data and the quality of the data that's received. And I know that Mark and Ian are very lucky to still have long hair because they have been pulling their hair out incessantly over the last year as they've struggled with our lack of data at their fingertips and the curious nature that the data arrives in. What I've had to do myself and to encourage others is to pull back from that daily firefighting, those operational issues and the winter pressures that take up our time and take us away from the most important, which is that strategic planning and implementing those changes. And I'm sure you can all feel the same as me. Everyone has an opinion of lean. Absolutely everybody. They've all got a story to tell you. May be good, may it not be. The phrase that I've heard at Portsmouth used is leaned upon, which is always not a good one. It's been really challenging listening to that, educating people and turning their mindset around to the positive aspects of lean. Sustainability of implementing change is always challenging. It's been no less challenging for us, and standardisation of any process. I have a thought that we do have standardisation, but it only lasts for as long as that nurse is in charge of a shift. And then we have another nurse or another manager, and we have standardisation just for their shift. And so it goes on over the 24-hour process. We have learnt huge amounts in the last 18 months with lean and would change a lot of the ideas and the concepts from the way we did things at the beginning of the pathway. LEA's heart would often sink as we had a mapping journey and a mapping exercise, and we'd fill the room with as many people as we possibly could, whether they were relevant or not, whether they were keen or disinterested. And actually, most of the time, we missed the key stakeholders who should have been in the room. I've learnt from them to deselect things on that matrix which actually aren't essential or won't have the biggest impact on that pathway of change. We can't line stop in the NHS. Sadly, it's a 24-hour-a-day service. But actually what we do now when we can't line stop is actually root cause why we've run into the problems that we've run into. Obviously there have been challenges, but thankfully there have also been things that have gone well. For me, finding my clinical champions has kept me sane. We've had a huge amount of support from senior clinicians right down to healthcare support workers. We've had excellent people who have just run with our ideas and have been able to disseminate the positive things. Light bulb moments when you've been sat in a meeting and the medical director starts talking about lean, or we were at CD4, the Clinical Directors Forum this week, and they were talking about how bad batching was. One of our greatest challenges when we started was our senior physician, and I sat in a meeting with him last night, and though he'd never say that he was talking about lean, he was talking about having a pull model from MAU. Those moments keep you going. I've talked about implementing operational changes, and I cannot stress how important it is to get the stability, as Ian said. There have been improvements in patient care. We now have a discharge round in our medical assessment unit, which is getting between 6 and 8 patients home every day rather than being admitted, taking that waste out of their journey. And with that data, we've been able to empower our facilitators to make changes. In the last few minutes, I'd just like to talk to you through an example of one of the work streams and the particular role that as a value stream manager I've played in that. Our medical assessment ambulatory service takes GP referrals from the community, has a consultant on call for advice and assessment, oversees our DVT clinic and assesses the patients prior to admission. When we first started to work with it, it had no ops management, no visual management. It was perceived and probably was clinically unsafe. There were long and distressing waits for the patient and the relatives. It was time-consuming for all involved to manage. There was batching, push not pull, significant amount of noise around the whole process and distracted people from the tasks they needed to do. And it significantly increased the patient's length of stay. The first aspect of my role in supporting this work stream was around the demand and the analysis of the demand data. Initially, this involved huge amounts of chocolates. They had no electronic data. They had folders and folders and folders of paper data. And my facilitator sat for days and days and days, and I fed her huge amounts of chocolate as she collated this data and made it electronic. I then needed to work with the 7 acute physicians to support them in understanding that actually what she has translated from paper to electronic whilst eating chocolate was actually their correct demand, because it didn't show a picture of what they felt was their true demand, mainly because the patients had been sat in chairs for hours prior to admission, but actually this was their true demand. And what I needed to do was to work with them with that data, bring in their clinical director to support me in that, reflect with other MAU assessment units in the area so that we were comparable. So lots of work with the consultants then that actually it wasn't the role of the facilitator to undertake, but felt was my role. And actually until they had agreed that the demand and we had established that demand, we couldn't take that next step. The facilitator has moved on, but reflecting back, one of the most important roles I feel is now to take from that value stream is to make a correct and sustainable process. So working with the operational team, so we do now have an electronic process for recording that data. and it will also save me buying mounds of chocolate in the future. You've seen this slide before. Mark showed it earlier on his talk. This is our patient journey that we mapped for a patient with shortness of breath. And if you think it looks chaotic, I'm sure most of you who work in medicine will understand it feels that chaotic most of the day. We'd moved with the medical assessment team to map in the process. My key role there as a value stream manager was to ensure that we had the right stakeholders at the event to map that process, to raise their awareness of what we were going to do, ensure their engagement, and actually for some of my senior colleagues, have a talk with them about what lean meant, what we were going to do, some of the vocabulary we would use, so that actually they looked, felt, and were perceived that they knew the part of the process that they were going to be in. There's nothing worse than being a senior person in a room when you actually don't know what people are talking about and people expect you to. So something about maintaining their credibility. Obtaining people's engagement with new processes is always most challenging. The other aspect of my role when we're bringing key stakeholders together is to be aware of the relationships, the interdependencies that people have, the connections, the sensitivities. We all know that there are histories in the NHS that go back many, many years, and things can go horribly wrong by sitting the two people next door to each other or even putting them in the same room together. So having that senior awareness that perhaps the facilitator may not have or the external consultants won't have to ensure that we get the best out of any process. As their line manager, I feel it's my role with the facilitators to ensure they are supported, guided and prepared for the day, to oversee the process and keep it on track, and then at the end to agree the work streams as we move forward. What we have done with the medical assessment unit is to implement visual management as we've moved forward. My role within this has to be engage, educate, guide, support and listen to identify the clinical champions who will take this forward. The facilitator can't be in the medical assessment unit 24 hours a day, so it's finding those key people and working alongside those at a senior level to engage their support. In this case, at the medical assessment unit, it's been a forward-thinking, active, acute physician. It's to support the facilitators in the highs and lows of implementing change, engaging team agreement. It's also putting my patient care improvement armour on and reminding everybody when the going gets tough exactly why we're here and what we're doing it for. And acting as the champion within the plan, do, check and adjust cycle of the patient status boards, essential in the medical assessment unit in reducing length of stay and improving the quality of care for the patients within their ambulatory journey. I feel that this last statement encapsulates the overview role of the value stream manager in any change process, to be the champion of the patient's perspective. When we were at LEA on our planning day for today's summit, we struggled to discuss and agree on what a value stream manager really was. And it was not until Mark was talking through his draft slides that he brought out the slide he showed you earlier of the cocks in the boat. And we all had our light bulb moment. The value stream manager mirrors the role of a cox in a rowing boat, to balance the pressures within that boat, keeping everybody to tact, leading, guiding, supporting the team that are rowing that boat. The cartoon element of this slide does not reflect how a value stream manager should work with the team in charge and the poor cox rowing, but actually sometimes that's how it feels. And the one piece of advice for me would be, don't be in your value stream boat alone. Ensure you have the support and the guidance of the team around you. Thank you.